Change in this schedule. So after Carolina, we'll have Bhargavi and then Anton. Carolina Danovaro will start things off for us, and I'll just introduce her, and then she can start her presentation. So Carolina works with the Strategic Immunization Information Group at the World Health Organization. She focuses mainly on the analysis and interpretation of global immunization data, supporting improved immunization monitoring in countries and development of methodologies and processes to improve routine immunization monitoring and data quality. Between 2004 and 2015, she was responsible for immunization data quality and strategic information at PAHO in DC. During her time at PAHO, she led an initiative to improve immunization data quality and to guide member states in the planning, development, and implementation of electronic immunization registries. Before joining PAHO, Carolina worked at the International Vaccine Institute on typhoid and cholera vaccine demonstration projects in Asia. And before that, she was a fellow of the National Immunization Program at the CDC. Carolina holds a medical degree from Pontificia Universidad Católica of Chile and a master's in epidemiology from the London School of Hygiene and Tropical Medicine. So Carolina, whenever you're ready, and for all our listeners, if you have questions, please put them in the chat and we'll collect them in the end and have a discussion with the speakers. So Carolina, about 30 minutes, and then we'll have common discussion in the end. You're muted. No, yeah, again, you're muted.
Okay, now that I found the unmute button. Good afternoon, good morning, good evening, everyone. As I was introduced, I work with WHO, and I'll be talking to you today about the massive impact that the COVID-19 pandemic has had on routine vaccination and vaccine-preventable diseases. So my presentation is divided in two parts. The first part, I will be talking a bit on the impact in of COVID in essential health services, including routine immunization, in campaigns, in vaccine introductions, and in the surveillance of VPDs. And then the second part will be more on what do we do? We need to recover, build resilience, and strengthen our immunization programs this year and beyond. So this slide shows what countries reported as disruption to various essential health services. And this slide is data that represents what was happening in the last quarter of 2021. So until very recently, countries were reporting massive disruptions in the provision of essential health services. Among those services, of course, immunization was one of those that was disrupted. Then in 2020, we saw major backsliding in childhood immunization. We had a decrease in the global coverage with the diphtheria, tetanus, pertussis containing vaccine. We estimated it going back to 2009 levels, even though that might even be a bit of an overestimate, because some countries were not able to really estimate precisely what was the level of coverage they achieved in 2020. But with this data, at least 23 million children missed out on basic vaccines. This was 3.7 million more than in 2019. This is really the first time that we have more children missing out on vaccines than the year before. And about 17 of these 23 million did not receive a single vaccine. So that's a problem, and not even receiving the basic vaccines in childhood. Then, however, coverage was really differently affected by the different WHO regions. So here you would see that, to orient you to the slide, you have the different WHO regions. The yellow line is the Western Pacific, the more orange is the European region. And those regions were the least affected, and they started with high coverage to begin with. But then you have regions such as the Southeast, Eastern Asia region with a massive decline. Then you have the region of the Americas in blue that has been declining already to begin with. Since 2016 was going downhill, and more so with the pandemic. Then you have the Eastern Mediterranean region that had improved and then went down. And the African region that, even though didn't decline that much in 2020, is the region with the lowest regional average of coverage. Here in the graph of the bars, you do have the estimated number of the under-vaccinated children, and most of those children live in the African region. Then on the left, you have again just the number of the zero-dose children, where they live, and you have that most of them still live in the African region. Another side effect of the pandemic was a reduction or a slowdown in the introduction of new vaccines. So it's difficult to know what's a normal baseline, but we can see that in 2020, the last data for which we have final data available, there was much fewer introductions than in prior years. And there was no low-income country that introduced any new vaccine, knowing that there are many vaccines that they haven't yet introduced into the routine schedules. And the picture with preliminary data that we have for 21 is not much better. However, the countries were extremely quick in implementing a COVID vaccine. And this slide is already a bit old, so it's data from about February. We had already reached more than 50% of the population that had received at least 2 doses or the basic schedule with a COVID vaccine. It had never, with any other vaccine, we had never seen such a steep uptake of a vaccine. You can see in the other more shaded lines how, for example, the yellow fever, having existed for decades and decades, has taken many, many years to be fully utilized. So are we recovering? Well, we have preliminary data. We're working with the final data for 2021, but the picture is not that ideal. So here we have the massive reduction in monthly number of doses administered. This is DTP3, so the third dose of the diphtheria, tetanus, pertussis vaccine, and a big decline in the months of April, June, coincided with most of the lockdowns. However, in 2021, we are still seeing levels that are below what we were seeing in 2019, which is at the left of the slide. Is this due to COVID vaccination? We don't know. On top of disrupting routine immunization and coverage, we saw a massive interruption and stop of the implementation of vaccination campaigns. And you can see that in the first data point we have is the 15th of May of 2020, is that most countries that had a campaign plan for any VPD postponed it or really put a halt to their campaigns. The picture was much, much better in April of 2022. However, we are not yet at the level of having done all the campaigns that needed to be done, and also including all the cohorts of children who are supposed to be vaccinated. So we still have postponements, but what has been happening with the latest campaign is that there is more integration between different vaccines and other interventions. Surveillance was much affected as well. So here we have on the left of the slides, we have measles cases by months and WHO regions. So we almost saw no cases of measles in 2020 and then picking back up in 2021. How much was that an artifact of surveillance, and how much was that a factor of a result of all the distancing policies and confinement policies that were put in place? It's a bit of a mix. We also saw a decline in the reporting of acute flaccid paralysis, non-polio acute flaccid paralysis. So the surveillance was affected, and we are not yet at the levels of the pre-pandemic. And this is a problem because not only we might risk having outbreaks, but if we don't have a surveillance that is up to par, we may even know about these outbreaks kind of late. Now, again, this is a close-up to the other slide of the measles cases, and we are seeing a measles cases picking up in 2022 again. So this is just a map showing the countries with larger disruptive outbreaks in the last 12 months. And here it's slides from just about 1 month ago. It's the latest data we have, and you can see that most of the middle of Africa is really having outbreaks of measles right now, in addition to Afghanistan, Pakistan, and other countries. Polio, another set of bad news. In red, we have the traditional wild polio viruses, and we have the transmission still happening, of course, in Afghanistan and Pakistan. But unfortunately, we have seen cases of wild polio virus in countries that did not have transmission, such as Malawi and more recently in Mozambique. And to make things worse, we have massive outbreaks of vaccine-derived polios, type 2 and also type 1. So we have a massive problem with polio. And as you saw, with coverage declining and campaigns being postponed, it's difficult that this gets better anytime soon. The meningitis situation in the African belt, it's also problematic. We have seen more cases as well this year. And then I don't have a slide about the yellow fever outbreaks that also are happening at the same time. To make things even worse, there is a lot of domestic financing problems to pay for the immunization program, along with other interventions and other health items. So we have some list of countries of great concern in lower middle, upper middle, and even some higher income countries, where we are monitoring closely because there is concern that their budgets to be able to have spending for health are being really, really affected with the current situation. So what do we do? Well, we really are working with member states to try and have some guiding principles to build resilience for immunization programs through a COVID-19 vaccination, with the response to VPD outbreaks, with catch-up and of missed vaccinations. Remember, all these children who were not vaccinated in 2020 and 2021 in many countries age out of what's normal for vaccination. So it's a problem because we are accumulating susceptibles for the future. And then on top of catching up, we really want to maintain and restore immunization services. So early in the pandemic, we saw the problem of the children missing out on vaccines. So WHO put out a guidance for catch-up vaccination. And the strategies include intensified strategies to close immunity gaps, campaigns, intensifications of routine immunization, and really implementing catch-up vaccination as a routine activity through primary healthcare. And again, this is not as common as it might sound to some people. Many countries, after you age out of the usual age of vaccination, you become too late to be vaccinated, which is a big problem now that you miss your opportunity during the main years of the pandemic. So what are the guiding principles that have been put forward for recovering, building resilience, and strengthening the immunization in 2022 and beyond? Well, there was a document of guiding principles that was endorsed by the Strategic Advisory Group of Experts to WHO, the SAGE group, in April. And it was developed taking into account the current context, the priorities. It was received feedback from various people, and it includes 25 guiding principles and recommendations. And of course, these are put forward so that resources and support can be also mobilized towards these recommendations. So these guiding principles have two main areas. One is to immediately close the immunity gaps and recover, because we are not out of the mess. We are really still having problems. We are looking at the 2021 data, and there are some countries where I have been working on immunization for over 20 years, and I had never seen such a disaster. where countries have declined over half, where countries have had stockouts lasting 12 months of some routine vaccines. So we really need to close these immunity gaps. And then just thinking more on sustainability, how we strengthen our programs and build more resilience. So when these massive shocks happen, we can be more prepared to take them on. So here we have strategies to close the immunity gaps, the strategies again, and surveillance. Some examples here, just for illustration purposes, massive campaigns that have happened, and these campaigns that normally just happen with additional doses are now being also used as platform to bring people up to date with their vaccines. So 3 countries from 3 very different parts of the world, just to highlight that we must integrate, we must use the opportunities we have to try to close the immunity gaps. Then addressing the restrictive policies and practices. As I was saying, many countries after you're 12 months old, or in some countries that have a vaccine recommended in the 2nd year of life after you're 24 months of age, nobody even checks your vaccination card. So you are missing out on your IPV, for example, that in many countries is just 1 dose. And basically, if you don't receive any IPV dose, you have 0 immunity against the type 2 poliovirus. Also, you miss out on completing your vaccination with diphtheria, tetanus, pertussis, Haemophilus influenza type B, hepatitis B, etc., etc. Again, massive concern with the outbreak-prone diseases, but also with leaving these cohorts of children half protected through their life if we don't catch them up soon. So this is just to illustrate how in Southeast Asia, the countries were really quick are changing their policies to change the maximum age. Because again, many had a false really restriction for age. Now for building resiliency, we have important massive challenges. We have our human resources, our vaccinators, our public health workers, people working in districts are overstretched. They have had to cope with COVID, and then on top of that, with every possible outbreak and having to vaccinate routine and catching up. We also have seen the hesitancy linked to COVID-19 vaccines in some countries has spilled over to routine immunization. So people before never doubted about the vaccines for children, and now they're questioning them. Also a movement of resources with more pressure to prioritize COVID vaccination over routine. Financial challenges. It's more expensive to vaccinate now in general, because you still do it with more personal protective equipment, etc. And the financial resources have been shifted. And of course, we don't know what's happening yet with what the future holds for us with COVID vaccination, for example. But we do have some opportunities. And I think, and among these opportunities, we have strengthening that can be done and is being done, particularly for the supply chain management and cold chain. The disease and adverse events following immunization surveillance have been strengthened in many countries. So as systems prepare to be monitoring any adverse events related to COVID vaccination, the whole system to monitor adverse events have been strengthened. Social listening also has been strengthened. The use of real-time monitoring and digital tools has exploded, and that can really be leveraged for the future. Many countries have made partnerships with the private sector that were not in place before, and those can also help with routine immunization and even surveillance. Also has been useful to promote vaccines, just not for children, but really life course immunization and more integrated service delivery and expanded partnerships. So again, 2 examples just to highlight countries with good experiences combining delivery, for example, for COVID and routine vaccination, and in Bolivia, strengthening the adverse events following immunization surveillance. There are many areas of synergies, but what most people have indicated that is an area that has again boomed, and it's an opportunity to capitalize on these gains is the area of digital health. Hotlines, mobile applications, more real-time monitoring, more timely use of data, etc. So countries are investing in data systems, which can be really helpful for the future. So in conclusion, we have had over 2 years of massive health system strain and disruptions. We have immunity gaps that are attempted to be closed, but we have many gaps still. Our goal is to build back better rather than just go back to business as usual as pre-pandemic. And we have some opportunities to leverage the recovery and the vaccination with COVID-19 towards resilience and strengthening healthcare. But we do need to adapt strategies, policies, and practices to the current context and the many, many challenges. And I'll stop here. Thank you very much.
Thank you, Carolina, for this fantastic presentation. So for all our audience, remember, you can put your questions in the chat, and we'll ask them, collect all of them, and ask all of the speakers in the end. So we're a little bit ahead of schedule, but I think that's okay. We'll have extra time in the end for discussion. So we can go on to Bhargavi. You're there, right? Okay, so our next speaker is Bhargavi Rao. She's a clinical associate professor in humanitarian health at LSHTM, and also works part-time as a malaria and infectious disease advisor at MSF. She has worked in humanitarian responses across multiple contexts and is a public health clinician with a PhD in infectious disease epidemiology. So over to you, Bhargavi.
Thank you so much. And just to say, I'm sort of representing both MSF and the London School of Tropical Medicine today. And I guess my talk will probably be a little in two halves, really. One around just what it looks like to deliver vaccines and in humanitarian settings, and the impact of crises on vaccine-preventable diseases. And then in the second half, perhaps following on from some of Carolina's talk, just looking at what impact the pandemic has had in humanitarian settings, and particularly the implications for vaccine-preventable diseases. This is pretty, so I just wanted to start, oops, let's have a look, how do I make? I wanted to start because I wasn't sure how many of you really, when you talk about disruptions and things like that, sort of to put that into some sort of reality. When we talk about humanitarian crises, there's lots of terms used interchangeably, and frankly, there's a paucity of definitions. I often work with modelists, and I find that almost everybody just talks about camps, and I think that clearly that we have a sort of a typology of what we would say are these sort of humanitarian crises with public health consequences. Of course, we talk about mass displacement into camps, and examples of this would be somewhere like the Rohingya refugees, South Sudan, Tigray at the moment, and Tigrayans in Sudan. You also have mass displacement into host communities, and so people who don't live in camps but still represent a humanitarian destabilization. So they would be sort of perhaps Syrians in Lebanon or Jordan, Ukrainians currently in Poland, large swathes of DRC, Central African Republic, and South Sudan. There's a sort of an idea of, I call it entrapment, which is chronic inability to move due to insecurity. And that is large parts of Yemen, undoubtedly will soon be Ukraine, but again, DRC and CAR. Then perhaps ones that we sort of see with regularity is this slow onset food insecurity causing humanitarian crises, and that's the Sahel or the Horn of Africa. It's complete collapse of state functions in terms of Venezuela, as well as the sort of the traditional thoughts of kind of sudden onset natural disasters. And if we look at the numbers for these. And just know that kind of the difference here is a refugee is someone who was forced to flee their country of origin and is unable to return due to a demonstrable threat. They receive protections under international law, particularly about refoulement, essentially that they cannot be transferred back, versus an IDP or an internally displaced person. They're forced to leave their home, but they seek refuge within their own country, and therefore they are under the protection of their own government. So they have rights, for example, to receive humanitarian assistance, even to protection against violence, but importantly, their own country, which is often the state persecuting them, is responsible for overseeing those rights. And so it becomes a little bit of frankly, a joke. And what we know is that the majority of displaced people are actually IDPs. And you know, we think that there are around 84 million people who have been displaced by violence. Those numbers are much easier to estimate by the end of 2020, start of 2021. The other sort of figures are much harder to kind of get a grip on, but certainly we think around at least 1 billion people live in about protracted crisis, and if we look at the 84 million people that were displaced at the end of 2020, that is double the amount of a decade ago. So undoubtedly, we're living in a time where humanitarian crises affect more people than ever before. And as a result of this, about 1 in 95 people are displaced and come under these terms. And although numbers may not look great, in public health terms, these populations matter much more than just their numbers, because they account for a disproportionate share of preventable mortality, morbidity, and disability. Okay, and this is perhaps what most people think of as a classic humanitarian crisis. This is Bentiu Protection of Civilians Camp in 2014, where 150,000 people suddenly got displaced into a camp. There was extreme flooding, violence. I was the epidemiologist there, the camp epidemiologist there at the time. And this is, in a sense, what we do when we have an acute crisis like this. These are the top 10 priorities that most humanitarian agencies look at for a start: the initial assessment, measles immunization, Watsan, food and nutrition, a little bit further down, control of communicable diseases and epidemics, and then surveillance. This slide is from a paper written by a colleague of mine from LSHTM and ex of MSF and Save the Children, Francesco Checchi. And here he sort of tries to map the domains of public health issues and information that might be relevant to look at when we're starting to look at the public health consequences of humanitarian crisis, in particular about the excess morbidity and mortality, which is what humanitarian action is looking to address. And what you see here are these crisis emergent factors, and they're in red, and how they then act on each other. And then we look at some of the downstream impact. So there are some sort of key public health outcomes here, such as nutritional status and morbidity, and then downstream impacts such as mental health and disability in yellow boxes. And then lastly, the green boxes denote kind of humanitarian public health services. So water and sanitation, vaccination, healthcare, things like that. And the relative sort of importance of these different domains is very context dependent. And I give you this because this is a sort of a framework that we then apply to things like models or kind of other sorts of forecasting and predictive methodologies to then look at how, in particular, we think certain pandemics, certain epidemics, outbreaks impact within these very particular populations. And then just quite a small reminder that often there are synergistic and multiplicative risk factors in these settings that particularly lead to this excess morbidity and mortality. And this is just, in a sense, showing the impact of humanitarian crises on vaccine-preventable diseases. So if we look at the map here, you can see that actually that map pretty much correlates with a map of humanitarian crises in this world. We can see that this is pre-pandemic levels I'm using here. What we know of at the time was of the 20 million children who are zero dose at under 5, about 14 million live in the African continent, and all in countries affected by conflict. These countries almost all have an EPI coverage of less than 75%, so below herd immunity thresholds. And what we'd certainly seen before the pandemic was the re-emergence of diseases such as polio, measles, yellow fever, monkeypox even then, pertussis, diphtheria. And then this is, on the other side is a table that also looked from Leach and Keki, also at the London School, looking at risk factors in conflicts, particularly associated with vaccine-preventable diseases. And you can see here that we've tried to sort of categorize which particular diseases we would worry about when we saw certain kind of risk factors within that particular humanitarian context, be it, kind of increased sex and gender-based violence, or if there's a particularly high birth rate, kind of what's associated with displacement or overcrowding, etc. But you can see that, again, very synergistic, and certainly that the overall message is humanitarian crises both diminish vaccination and increase the risk of vaccine-preventable disease. So what's different about humanitarian public health interventions? Well, in principle, nothing, right? Humanitarian action should basically support people to be no worse off than before the crisis. But in reality, in crisis settings, public health interventions are incredibly difficult, especially during that acute phase. And that's because interventions need to be adapted to achieve their effect within a very short window of time, and that's to avert preventable mortality. So in general, we go for population measures. We need to be able to cope with reduced access and security, and we need to rely on a potentially smaller and less skilled health force. We have to deal with unprecedented numbers of coexistent risk factors, much different to any other vaccine campaign in any other lower middle income country, and also function in spite of an absolutely disrupted healthcare system. And that means cold chain supply, the need for repeated vaccine campaigns, etc. Really handicapped by the idea of limited data, definitely initially, but also quite often in the longer term. Reductions in health information getting to people, including misinformation and disinformation, and then also often really quite hampered by politics. So who makes the decision to intervene, who provides the funding, and the availability of vaccines, and kind of hence the sort of the dysfunction of the humanitarian buffer. And if we just think about kind of what reduced access or functioning despite a disrupted healthcare system means, this is what it looks like. It means delivering via boats. It means people with grab bags because conflict emerges all the time. It means delivering healthcare in tents. It means healthcare facilities that are attacked. It means, trying to keep cold chain by putting cold boxes on the backs of motorcycles. And it means case management of something like cholera, just out like this in Haiti, kind of on the ground with multiple people without enough beds. So this is really what outbreaks look like, and coping with these sort of factors in a humanitarian setting. A quick point on data, which is just how hard it often is so I often get asked, kind of about real-time modeling, or kind of, well, we can predict X, Y, Z if you give us this data. And this is a review done about the amount of data that was available within the first 6 months of a crisis, kind of now this is a little old data, but if you just look, you can see kind of quite how difficult it is to get any sorts of available data in a crisis situation that is actually actionable or appropriate for decision making. And then a very quick point on responsiveness and funding and the public health architecture. So this is one sort of side of this is for refugees, which UNHCR oversees, and then there's UNRWA for Palestinian refugees, and then the sort of the IDP sort of scenario. What you can see is sort of every system then activates its own cluster for this public health system. But the important point here is that all institutional donors have to go through these systems, and you can see kind of how much layering how many decisions, how much coordination is required in order to make a decision about whether to vaccinate or not. And really the only two independent actors here are MSF and ICRC, who have their own funding and remain independent. And so the humanitarian mechanism for vaccine provision was developed by WHO, UNICEF, MSF, and Save the Children to enable civil society organizations, governments, UN organizations to really quickly procure vaccine supplies on behalf of populations facing humanitarian emergencies. And that started in 2017, and you can read yourselves about kind of the difficulties of this and how, frankly, it has not worked in terms of COVID, but and continues to be problematic with other diseases such as measles or yellow fever, etc., diphtheria, what have you. And part of this is because also the declaration of an epidemic entails an implicit recognition of failure of control and prevention programs. And decision-making is aggravated by debates around the appropriateness of timing of use of vaccines. When is it too late to implement an intervention in response to an epidemic? What's the effectiveness of that vaccine? The risk of vaccine interventions diverting resources away from case management interventions. So in order to sort of help some of that, there is guidance and a framework for decision-making developed by the WHO, which looks at kind of how you then decide what to do. Step one is to determine the grade and to determine the risk and the grade of risk of the vaccine preventable diseases. So, you know, is there a level of risk specific to that VPD? And obviously something like measles or cholera would be very high. Something like, I don't know, monkeypox would be much lower. And then there's a level of risk due to general factors, sort of, you know, kind of whether that is things like nutrition levels, birth rate, access to healthcare, things like that. So once you've made a decision that you would definitely consider vaccination, you then look at, can you actually get access to the vaccines and its amenability to a mass campaign, because targeted campaigns are often much more difficult in these humanitarian situations. If you have that, then you have to assess contextual factors. Can you say political instability? Is it secure enough? Do you have enough staff? And is there consensus between all of these key stakeholders? And only then can you implement a vaccination intervention. And this is a review done, again, just published a couple of months ago in Vaccine, that looked at humanitarian crises from 2011 onwards, I think, and in sort of these main settings. And you can look at when the timeliness of these vaccine campaigns, and you can, and then the bottom sort of bar chart basically shows the fact that how many of these crises had VPDs that were assessed to be high or moderate risk, and then actually how many were able to implement mass vaccine campaigns targeting those VPDs appropriately. And you can see that, you know, in some cases, such as in Zimbabwe, which is pretty unusual, and that was really around kind of cholera, that you know, almost all the VPDs were appropriately addressed. But I think, you know, you could really agree that in most of the other countries, and particularly in states such as DRC, Somalia, overall, as a humanitarian community, we have not been able to deliver on mass campaigns targeting VPDs appropriately. And if you look at some of the timings as well in the table, you can see that basically, you know, measles was provided in almost all, similarly polio as national campaigns, but you know, something like Hib or PCV or meningitis, despite being high risk for excess morbidity, are often fairly neglected, and you know, it shows a sort of a failure of the system, in a sense, to both either be able to assess priorities or actually just be able to deliver as a result of contextual factors. I think Carolina's shown some of this data already, but I think what we have certainly seen overall in terms of COVID-19 on VPDs, and she showed some data, and I'm sure Anton will show some later, is that those zero-dose under-vaccinated children in humanitarian crises have had their situation worsen. And certainly what we see is that surveillance, especially in humanitarian crisis-affected areas, has also decreased, putting these areas in even greater risk. But perhaps then I flip this and say, actually, let me just go back in one sense and say, the other thing I would say is even before the COVID-19 pandemic, as I was saying before, we know that the world was experiencing an increase in vaccine-preventable diseases, so increasing rates of diphtheria, Hep B, measles, meningitis, mumps, tetanus, all had increased, perhaps in part due to vaccine hesitancy and in part due to resource shortages, increased numbers of outbreaks globally. And what we do know is, as I said, the impact of COVID-19 on these VPDs has been profound. And Anton will speak a little bit more about just the numbers of increased outbreaks as a result of this. But given the experience that many of us have had over these last 2 years, I wanted to talk a little bit about the aftershocks of the pandemic and what it means for pandemic response in humanitarian settings. Conflict zones are the sharp end of pandemics. They're communities that are already living on a knife edge, and any additional shocks can be catastrophic. The challenges of a pandemic and its aftershocks can deepen the fragility of a humanitarian crisis, spiking existing humanitarian needs, accentuating the impact of violence and conflict, increasing global poverty, heightening that instability and inherent tensions of a crisis. These are deeply fragile places in which to launch a pandemic response. And as we've seen with COVID, but also those of you who've lived through Ebola, cholera pandemic, Zika, etc., pandemics can't really be addressed solely as health issues, and they must change humanitarian work, and we have to draw our lessons from them. And firstly, perhaps unrelatedly to VPDs, I want to make the point that international humanitarian law must be better respected to protect civilians and their infrastructures from future shocks, such as the one in this in these pictures. Violations of international humanitarian law, cities bombed to rubble, mass displacement, they are all enemies of any sort of pandemic response or preparedness. Countries where health services have been destroyed by war stand little chance to treat or contain outbreaks, much less diseases with pandemic potential. We know that mortality rates spike dramatically in the absence of care. We know that pandemics also, so we know that mortality rates spike dramatically in the absence of care, but attacks, including cyber attacks on healthcare workers and facilities, have become depressingly normal. The WHO passed a resolution in 2016, and a legal framework does exist, but it is mostly not enforced. In 2021 alone, over 800 confirmed attacks on healthcare took place in emergency affected countries and fragile settings. And these attacks deprive people of urgently needed care. They endanger healthcare providers and they undermine healthcare systems. The top picture is of Kunduz Hospital in Afghanistan, an MSF hospital that was bombed for over 4 hours by US troops, despite them knowing where the hospital was and that it was a place of healthcare. Many of us recall the outbreak of Ebola in West Africa in 2014 and 2015. And the biggest threat was ultimately not the disease itself, but the lack of infrastructure that could help prevent its spread and provide adequate care for those who are sick. And that's a disparity that explains why Ebola exploded in some countries and yet was quickly contained when cases appeared in others. Controlling vaccine-preventable diseases is not only about putting vaccines in people's arms, it is about addressing deficiencies in public healthcare systems. To address the next pandemic, healthcare workers and humanitarians are our first and last lines of defense, and they must be protected. And we need adaptations to programs to bolster training, capacity build, develop surge capacity, of preparedness, of localization of staff and decision-making, and that critical importance of healthcare systems. At the bottom, two pictures, one is of a burnt down Ebola treatment center in DRC, and the other is of polio vaccination workers in Pakistan. We know that misinformation and exclusionary responses can fuel unrest and instability. We've seen the impact of one measles vaccine paper on immunization. In conflict settings, misinformation and disinformation can kill. And failure to gain trust, to feel that all groups have access, inequitable distribution of scarce medicines or protective materials, they all trigger violent flare-ups and destabilization, and that kind of perpetuates the crisis as well as the conflict. Prioritization and keeping kind of baseline needs in focus is something that we have struggled to do during this pandemic, and it's something that we all need to get better at, particularly when we're confronted by a bigger, newsier challenge. You know, the numbers of columns of inches now in monkeypox is ridiculous compared to COVID, which is ridiculous compared to the, you know, ongoing crises in malaria and TB and in measles. We have to look at the landscape of needs, and rather than creating trade-offs between a COVID response and other responses, you know, the war wounded, those with chronic diseases, they've still got to be treated. Mental health and sexual violence responses need to be scaled up. And if you don't, you just continue that cycle of exclusion, of ill health and violence and conflict, making the humanitarian crisis worse, making diseases such as vaccine-preventable diseases worse. We've already seen the impact of focus of one pandemic on vaccine-related performance. We know that during the Ebola epidemic, the number of maternal, neonatal, malarial deaths increased. And when we talk about prioritization, we also have to think about when implementing a response in a complex crisis setting, these responses must be built to reach the most vulnerable and marginalized community members. It's a bit of a shtick to say no one is safe from the pandemic until everyone is safe. But what we do know is pandemics affect some people more than others. We must ensure those responses reach those who are less visible and those who are silenced, displaced people, those working in informal sectors, areas controlled by non-state armed groups, detainees, people with disabilities, racial groups, women and girls, as well as sex and gender minorities. So we need, when you guys are modeling your scenarios, be really aware of the choices we are making. Where for example, something like if we're looking at home-based care, think of a very infectious disease with a long period of infectiousness. Think about where that burden falls in terms of on women and girls, and how do we then also protect them when household transmission is a key part of the bulk of cases. We need to think about better data, undoubtedly. An obvious lesson for those of us who work in humanitarian emergencies is that the lack of quality data has blinded us to the consequences of the pandemic in humanitarian settings, of the COVID-19 pandemic in humanitarian settings. It's obvious now that wide-scale transmission and deaths have gone undocumented. Inadequate testing, poorly implemented surveys, poorly implemented contact tracing, poor mortality reporting, limited seroprevalence access. They've all frustrated our ability to understand the situation and also to predict and respond. But I think one thing I would also say when talking to academic colleagues, to other agencies, is that with data comes risks. It's the new oil, and our thirst for it must not blind us to the risks, whether it's mapping, whether it's sharing with donors. We need to be very careful about the security of our data, and particularly the implications of sharing, and to treat that data as incredibly valuable. And we need to also therefore invest in alternative methods of data collection, particularly in emergencies, and including with the communities themselves. And it's become really ubiquitous, I think, in the outbreak community to talk the outbreak sort of scene, to talk about community engagement and how important community partnerships are. We know that responses will only be effective if there is community trust and there is community engagement. And we must learn from COVID-19 the lessons that we didn't really learn enough from Ebola in terms of trust. It takes years to build, a moment to destroy. And even in these conflict-affected environments, health actors need to really build trust by listening to communities and acting with transparency. And I would say for academic organizations to show that same amount of transparency and trust when dealing with humanitarian organizations in terms of how you use the data, how you analyze it, how you include people that have collected that data, often at great personal risk to themselves. The need to get vaccines to those hard to reach populations is not just a matter of ethics and justice, although clearly it is also very much that. Gaps in global immunization coverage leave spaces where viruses, bacteria can replicate unchecked, increasing the likelihood of new mutations, the likelihood of new variants. Whatever course either this or any other pandemic takes, it's imperative that they do not become pandemics just of the less fortunate. It is frankly criminal to me that large swathes of our world have not been included in the large global initiatives of vaccine distribution, access to diagnostics and antivirals, and how humanitarian access continues to be limited, not just to the tools that we have, such as the COVID-19 vaccine, but also to any development of new tools. And we see this very much with monkeypox already, compared to endemic settings, kind of looking at how monkeypox vaccine or new treatments are being made available and frankly hoarded by Western countries. It is immoral. But of course, none of this is new, and we've all been here before: Ebola, Zika, cholera, so many others. And I feel that, as a community, we've often promised ourselves we would reflect and learn after each of these huge events. And perhaps what's become clearer as COVID-19, this current pandemic, continues to rage, is that our global healthcare system is even more broken than perhaps we realized. This year, we lost the great Paul Farmer, an infectious diseases physician, founders of Partners in Health, whose work in certainly the humanitarian sector has influenced many of us. And I went to see him at a keynote speech at ASTMH 2017 in the aftermath of the Ebola epidemic. And he said, it keeps recurring again and again, that when we have scientific progress, when we have new vaccines, we have new diagnostics, we have new therapies, and yet we fail every time to put together an equity plan. And so I would encourage you all, when you when you're looking at your modeling, when you're looking at studies for looking at future pandemics, to keep this in mind. Thank you very much.
Thank you, Bhargavi, for excellent talk. Again, for all the audience, please put questions for all our speakers in the chat, and we'll go through them at the end of after this third talk. So our final panelist is Anton Camacho. Anton is the head of data science at Epicenter, the research satellite of MSF. His team supports the collection, analysis, and visualization of outbreak data to inform MSF's operational decisions. Prior to joining Epicenter in 2016, he was an MRC research fellow at the LSHTM, where he worked on real-time modeling of the Ebola outbreak in West Africa. He holds a PhD in infectious disease modeling from the University of Paris, research at the edge of mathematics, biology, and computer science in order to address public health issues. So Anton.
Hello, thank you for having me. Sorry, my voice is a bit broken. Okay, so I'm going to share my presentation. All right.
Great, thank you.
Yeah. So I'd like to thank Rose for the invitation and apologize for my voice. So when she asked me if I could talk about the perspective from MSF on the impact of COVID-19 pandemic on vaccine-preventable diseases, to be honest, I was a bit destabilized because that's not my area of expertise. So, but I thought I could just go and talk to colleagues who have better knowledge than me to try to better understand the situation, because actually it's a question that is I've been asked to several people at MSF, from media, from many media, to better understand the role of COVID-19, and I think also the request of Rose to participate in this workshop came just after this press release by WHO, stating that they were a perfect storm for measles outbreak. So there was all this, there was all this question to MSF. What do you think about this statement? And at first, like the reaction for the colleagues were that they wanted to be a bit cautious, like they were like, okay, the WHO say that, but they have like the numbers, like the global overview of immunization campaigns, and that's what Carolina showed you a bit before. But at MSF, we are in many places. We still have like a local view of what's happening. We don't have the same view. So I thought it would still be interesting to focus on a very local example. So I'm not going to talk about like a global situation, but I'll try to give you some concrete example of what happened over the last few years in a few places. And that's information I gather by discussing with colleagues that work directly in the countries we're going to talk about, and also because I understand that the audience is mainly people working in the area of data science and modeling. I think it's also a very good way of doing a better model, or is to really talk to the people who are I would say in the field, because it's very stimulating, and it can also change the way you see actually the numbers that you receive. So actually this statement was in end of April, and a colleague of mine pointed to me actually another press release by MSF, like almost a year ago, from MSF in Niger, saying that they had problems of vaccination right now in 2021 of measles immunization, and that the effect will be felt for years to come if they don't manage to complete this. So clearly the warning message has been here for some time, and so I talked with the medical coordinator of MSF in Niger to better understand what happened for MSF and what she saw over the last 3 years. So just a bit of context. So measles is a sub-Saharan country. You have a map on the right, and on the left you have your favorite time series, the measles time series over a 10-year period. And this is data collected through the routine national surveillance system. You have to imagine that people like in different areas of Niger, making phone calls every week, filling spreadsheets at the district level, and then merging that at the national level. And so this system has been going on for a while. And when we look at the data, we see this measles epidemics, like seasonal epidemic, that happened almost at the same time every year. And clearly, like the dynamic is quite changing over time. But what we see that in 2020, you have like a small outbreak, followed by a big one in 2021, and even bigger one in 2022. So the epidemic has reached the peak already, and now it's decreasing. And when you look at the geographical spread, it's also everywhere in Niger, in all the different regions. So that's the measles dynamic in Niger. And then if we look at the same thing for COVID-19, what we see is that we have 3 waves, much shorter time scale, obviously. 2020, like beginning of 2020, late 2020, and then 2021. So on the winters. This data, as you see in the map, comes mostly from Niamey, the capital, the bottom left, and is provided by the PCR confirmation system. And actually, when you look a bit more in details, you see that all these data mostly reflect international traveler testing, because during the period of time in this map, the PCR testing was mandatory to travel abroad. So that's what we see mostly in the data. And that's why also the number are very low. So what has been the impact of this, of COVID on Niger? What can we say about that? So first, when we look at the COVID-19, clearly there is big underreporting of COVID-19 cases and deaths in Niger. When you look at the national attack rate, it's 0.02%. It's difficult to have like fair comparison, like population, other indicators. But at Epicentre, we did a seroprevalence survey among healthcare workers in Maradi, which is a small town in rural Niger. So it's not comparable to obviously the general population, but what we saw is that the seroprevalence was super high, like around like 80%, 85%. So clearly it tells you a bit the gap, like the reality between, and that obviously the data is very underreported, the official data. In terms of like the feeling over there, it was really like during the first wave, not much happened. It was really during the second wave at the end of 2020 that really they noticed like that the government, the Ministry of Health reacted. There was like a lot of measures, a lot of communication, but clearly there was never a sense of a public health crisis, not like in Europe. There was no like overcrowded hospitals. So that was really the feeling of the Medco. But what happened is that in 2020, because of COVID, the people became really afraid to go to healthcare centers because they were afraid of getting infected with COVID. And this has immediate consequences. First, it's going to delay the time to seek care of people who have other disease. And for instance, in the case of measles, it might increase the severity of the patient that you see coming because they waited too long. At the same time, you're going to have lower routine immunization because like the parents, they will not bring the child to the health centers to get vaccinated. And obviously there will also be underreporting of those diseases because it's usually health center based. However, like fortunately, this initial fear really faded out in 2021. But at the same time, there was the time when the rollout of COVID-19 vaccine started. And actually, this also impacted the other vaccination campaign. Basically, any vaccination campaign that you would do in 2021, even like late 2020, there was the suspicion of a hidden COVID-19 vaccine campaign with a lot of rumors, and especially in Niamey, the urban city, because of bigger exposure to those fake news. So for instance, there was a security incident on the first day of a catch-up measles vaccine campaign run by MSF. So the catch-up, so you have the routine immunization that is doing like all year. And then you have the catch-up campaigns, which really target places where you know you have like a bad coverage. And then you also have the reactive measles vaccination campaign during outbreaks. And the same happened. There was this measles outbreak in Niamey. And after 1 week, they had to interrupt the MSF reactive campaign because actually there was a launch of the COVID-19 campaign. There was a very poor communication and no preparation of that. So people start to hear about this. So then they make confusion. and so what happened is that the coverage was really low, only 50%, they didn't continue the vaccine campaign, and MSF didn't do that because of all the confusion and the potential security incidents. So it just tells you clearly, mechanistically, why you see like sometimes low coverage, and what is the impact of one campaign on the other. Even if you want to do good, you have this outcome which leads to poor coverage. In 2022, we saw that measles restarted very suddenly and hit the country very high. And actually, when you look at where this happened, it actually happens also in places that were vaccinated by MSF, even with high coverage. So there's always this surprise with measles that tend to come back, even in places where you would not expect it to come back. And this can be due to population movement or also to other factors. And also surprisingly, like the places where you had like the most, let's say, vaccine hesitancy toward catch-up campaigns were relatively unaffected during this 2022 outbreak. So you see, like when you look in detail, it's very complicated to understand all the different factors. It's really like a mix of a lot of different factors that are difficult to really separate. Okay, so what was the general impression actually of MSF medical coordinator was, I guess not just on her, was the frustration, a feeling of frustration with the government response to COVID-19. I'm going to try to explain this why. What they felt that there was no questioning of certain recommendations that were taken and coming from high-income countries. And one of the best examples is the use of hydroxychloroquine, which was initially like really popularized by Professor Rao, who know as his face on many products, including beers. At the moment, they are still prescribing hydroxychloroquine to COVID-19 cases in Niger, and so you can see the also some impact of this pandemic, and so there was no questioning of certain recommendation, and also there was the application of policies sometimes without adaptation to the local context. So, for instance, we hear everywhere about the target coverage of 70% for countries, like a coverage, for COVID-19 vaccine. Niger is one of the top countries in Africa, has reached already like 20% for first dose and 15% for second dose. But clearly they are now like, I mean, they lost the momentum, and the momentum is almost finished. So it's very difficult to run those campaigns. And so if the policy is to reach 70%, they're going to involve a lot of time, a lot of resources, a lot of money to reach a goal that for MSF actors on the field feel that it's going to be like almost impossible and very time consuming and money consuming. Also, the fact is that the median age in Niger is 15-year-old. So if you want to reach 70%, you have to vaccinate, including most of the child above 5-year-old. So it's very tricky in Europe. So imagine in Niger. So clearly, like this application of policies, the adaptation is creating some frustration, and I mean we can understand why this number, but it's also this to be discussed. And finally, there was a lot of obviously with this response to COVID-19 that necessarily lead to some COVID business, which are the perverse effects of when you have a large influx of money for only one activity, because then you're going to observe some reallocation of resources to the highest bidder. So in this case, for instance, it was in 2021 there was this cholera outbreak in Niger, and even so they had like the vaccine to vaccinate, you have limited human resources to do it. So because of the prioritization of COVID vaccination, it led to a delayed cholera vaccination, which had a strong impact cholera on the Niger. And also now they are delaying the second dose. So you have also this effect. So okay, so that was the MSF slides. But there are also some good news. I really try hard to ask for good news when I discuss with the Medco and others. So the first big news is that there is no like very better access to oxygen in hospitals. So oxygen is essential for COVID, but also for other disease and hospitalization. So now they have much better access to oxygen supply. And giving the example of this Belgian consortium, we set up an oxygen plant. So that means that the supply is going to be sustained in the time. There have been also other technological improvements, but with more limited impact, let's say so far. Also, they have like a high potential for the future. So, for instance, the Pfizer vaccine was deployed in Niger, and so they had to build all the cold chain, which was not available before. So, clearly, in terms of like, I mean, there was only 400,000 doses. So clearly, in terms of impact, it's not going to be huge, and you could discuss the cost effectiveness of doing this. But clearly, on the long term, you can hope that this will improve many things in the access to vaccine in Niger. Similarly, there was a lot of gene experts that are used for diagnostic everywhere in Niger. But as she said, they were not used. So you know, they also hope that perhaps in the future it's going to be more used. And same for the respirators. They order like many they received many respirators, but unfortunately they didn't receive the equipment that goes with them. So that's also the paradox. Sometimes you rush for the high-tech product and you miss the other product you need to use them. Other good news is that due to the COVID-19, it led to some improvement in surveillance system, in particular through digitalization. So for instance, at Epicentre, we supported the Ministry of Health to digitalize their COVID-19 alert system. So at the beginning, they were really using like handmade system, using WhatsApp, pen and paper. And thanks also to another NGO, we replace it with proper software that really save time, because it is also like create notification, dispatch the alert to the right investigation team, etc. So they really like the system, and now they're trying to replace the current national surveillance system, which is still using Excel. But what we are seeing is that we have a challenge to use that outside of Niamey. As I showed before, most of the COVID system work mainly in Niamey, but the surveillance system works nationally in all the country. So now they are facing challenges that we didn't face during COVID. So there are still like a long way to do, but these are mainly the testimony of someone that really knows very well the situation in the field, not me, but the Medco. All right, so now we're going to change totally country, and we're going to add more complexity, because we're going to go to the Democratic Republic of Congo and to look at Ebola, measles, and COVID-19, because the country was facing 3 outbreaks at the same time at some point. So right now you still have like measles, COVID, and Ebola, but so now Ebola is there's an Ebola outbreak in Equateur, but the one I'm going to talk about was the one that happened in the North Kivu, Ituri, and South Kivu between 2018 and 2020. So So what I'm going to talk about is another type of activity that is doing MSF, but also mainly Epicentre, which is to do a vaccine trial. So we do vaccine trial in some countries, and this one was an Ebola vaccine trial during this 10th Ebola outbreak in the DRC, and that happened during also the COVID-19 pandemic. So just to put a bit of context, on the left you see the time series of the Ebola outbreak, and on the right you see a map with all the cases in this eastern part of DRC. And there was a vaccine that was used during this outbreak, which was the Merck vaccine, RVSV vaccine, which has a license. And we have efficacy data from the outbreak in West Africa in 2014. So the idea here was to introduce a new vaccine, a 2-dose vaccine, and to do a trial to try to measure efficacy. And for COVID, we had efficacy results very quickly because there was cases everywhere. But for Ebola, it's a big challenge. And also from ethical point of view, you cannot just do a trial in an outbreak zone when you already have efficacious vaccine. So there was a lot of discussion, but to tell you, like the trial started almost more than a year into the outbreak. Was already more than 3,000 cases reported. And when we started to do the first vaccination in Goma, which is the south part of the map, there was just a few cases reported there, and it was quite far from the epicenter. And on 10th of March, the first case of COVID-19 was detected, reported, and so less than a month after, we suspended the trial because we didn't want that the vaccination site become like clusters of COVID transmission. So there was all this decision taken, and by the end of June, the Ebola outbreak ended. So I mean, clearly there was no more question of moving to the epicenter or anywhere else. But that tells you how in a trial it's also very complicated to deal with all the different outbreaks. And here you have an example of their impact. Okay, so what was the impact of the trial suspension that happened on 9th of April? On the top you see the rollout of so it was a 2-dose vaccine. So you have the first vaccine on the top and the second vaccine below. And what we saw is that clearly, like in terms of the dynamics of the people going to the sites to get vaccinated, it started slowly, but it increased because of communication, because of community engagement. And so that is very good for a vaccine campaign. So here it's not a campaign, it's a trial, but it also helps to learn about how you would vaccinate with this vaccine and what would be the reaction of the population. So the vaccine coverage with the second dose, that's the proportion of people returning for second dose, before the suspension was 84%. And then we had like a 9-month suspension, where we tried to continue to stay in contact with the participants, but clearly it was more difficult. And so on this, when we reopened the vaccination site, we saw that the was much more difficult to get people for the second dose, and the coverage decreased to 66%. And so there was this team of social science at the London School who actually did a great job at trying to understand why it was like this. And what they found is that because of the delay to the second dose, there was some fear that the vaccine will not be as protecting because of the delay. It was supposed to receive the second dose after 56 days, and now it was 9 months later. There was also stigma that with this vaccine, you will get less protection, so less good. So they didn't want to go to get the vaccine. And also he was, so at the time when they were talking about COVID vaccine, because there was the first results of vaccine efficacy. And so there was a big confusion when we gave the second dose with the COVID-19 vaccine. People having rumors that you get there and actually you get the COVID vaccine instead of the Ebola vaccine. So another concrete example. And just to finish, I'm going to stay in DRC and so add measles on top of that. So now what you see in blue is the measles dynamic, the weekly number of suspect cases since 2026, since 2006, and up to now. And in red, I have highlighted the period of the Ebola outbreak, which is really at the same time as the measles outbreak. And there was clearly this feeling that because of the Ebola outbreak and the reallocation of many resources and also global attention to this outbreak, this measles outbreak was not receiving the appropriate attention and response, and even from MSF. So there was a lot of discussion, and you should look at this paper from Ducombe and Ginu that explain that much better than I do. But this situation is very comparable to COVID, not in the causes, but in the effect. Is that you have some reallocation and you have some delay response to a measles outbreak, and when you intervene, it's already too late. Like the outbreak is everywhere. So it really came to an end at the end of 2019, when there was like a proper supplementary immunization activities that were deployed, and that coincided with the start of the COVID outbreak. So perhaps there's also some problem with the data, but clearly this is the current understanding of what happened with measles at this time. The other reason is that you have some 3-year cycle with measles in the DRC, and so with the last outbreak starting in 2018, you would expect to see something starting in around 2022. In between, you had the COVID-19 that disrupted the routine immunization because there was delay in the supply of vaccine, for instance. But not only. So, for instance, there was a big strike of nurses in DRC during this period that also affected the routine immunization. So again, it's not just one factor. And so in 2022, the statement, for instance, that we see now from WHO, clearly there is a resurgence of measles. And when you look actually at the dynamic, is very similar to what it was at the beginning of the previous wave. So perhaps the surprise is not so much that you have measles coming back, because with a natural cycle, you would expect it, but it's more like the intensity and the fact that now they're fearing that this outbreak might be even bigger than the previous one, as we saw, for instance, in Niger. So in conclusion, and also for discussion, so what we see with COVID-19 is really like an aggravating effect on vaccine-preventable disease. And here I focus on measles, but you have also the case of other disease presented by the other speakers, and not only on the dynamics, but also on the surveillance and immunization. And that's a pattern that we see that are similar to other crises. So I discussed a bit the Ebola outbreak in DRC, but we also have the situation of the war in Yemen, where you have like a big disruption of the health system, and a few years later you introduce cholera, and you have this huge outbreak, and very difficult to respond to it. You have also delay in access to healthcare, which might cause you may see more severe cases, more severe disease. So the big difference with COVID is that it's not a situation you see in one country. It's a situation you see in many countries at the same time. So you have this multiplicative effect that now you have to fight you're in several battlefields at the same time, and that's make the response very difficult. And it's very complicated for MSF decision makers to decide on what emergencies they have to intervene. The other problem is the amplification effect with other crises. So, for instance, we are now facing like malnutrition in many countries, and malnutrition in measles. Let's say they can really so malnourished children will be more less immune and more severe measles. So you have like this amplification effect, more severe cases when you have these two crises at the same time, and we're going to face that in the already and also in the coming months. So what is MSF doing right now? So what has changed? This pandemic has changed in the way they do things. It was not so clear, but clearly they are reinforcing the importance of emergency preparedness procedures. So there are a lot of guidelines on what to do when you have this, and this. And so now they are reflecting on new scenarios, and it falls them to rethink some of that and to be better prepared. We expect to see like a lot of out of season outbreaks, which are also like surprising, like respiratory disease mainly in coming months due to the decreased immunization campaign. And to finish on a slightly more happy note, clearly like the COVID pandemic, we saw like a very fast development of new vaccine with new technologies, and clearly this will remain a benefit for the future in terms of research and development, but also licensing procedures, etc. There was really like this idea that it's possible to do that now faster than before, and also it's something that at the moment we see, but it's really the fact that now like everyone is aware that we are in a globalized world, and we are like a village, because we see with monkeypox now is that you have this global awareness that goes very fast, and people know when you have a case somewhere, they know, they feel like concern. Whereas at the beginning of the COVID pandemic, you remember like it was, oh, this is just like a few cases in China, like we'll never come here. So also this is like a change, and it should help to better hopefully respond and create intentional response to outbreaks. Voila. Thank you for your attention, and I hope I didn't took too much time.
Thank you so much, Anton, and to Carolina and Bhargavi. This was a really wonderful session spanning really important and eye-opening topics in the space of destabilization and VPDs. So we have several questions, and like audience, please put them in the chat, and we'll go through these questions and like let all of you respond. So John, maybe I'll start with one of them and you can go on to the next. So one of the questions is, what is the heterogeneity? So we've seen interesting results at country level and across continents. Can you talk a little bit about the heterogeneity, spatial heterogeneity, both in immunization coverage and the impact of the pandemic on the immunization coverage, rather than just the coverage itself, and what data are available to track these gaps, and what are the ways to strengthen that? So I'll keep it open. Any one of you?
I think I can take that one. The pandemic certainly has not been heterogeneous in its impact to immunization. You have countries that started with a really strong immunization program that had a little bit of a hiccup and recovered fairly quickly. And that's the case of many countries in Europe, for example. They were quickly to recover. Then you have some surprises, let's say, where, for example, in Latin America, countries were not doing bad in immunization in general, even though coverage was declining in the last few years. But the pandemic was just a disaster. It really hit the health systems so hard that they haven't been able to recover. And
And there is huge risks in that part of the world, for example, that were a bit surprising in a way, the magnitude. Then you even have countries in other parts of the world where the magnitude of the impact has been so surprisingly high. For example, the Philippines. You have stockouts, as I mentioned, in, again, surprising countries like DPR Korea. So it has been really difficult to have a typology of countries almost to really understand why some countries were so much more affected than others. And then you had countries where the systems were fragile to begin with, and then just you blow a little bit and they collapse. So what data we have? We are in the annual period of data collection. So we're getting data about 2021 from member states. Our reporting rate is lower than what it used to be pre-pandemic at this time of year. So we have received about 159 countries out of 195 so far. And that's a problem too, because it's really difficult to have the complete picture when you have some issues with reporting, and that got affected quite a bit. So we do have mechanisms to monitor selected countries month by month. So we just monitor the number of doses. The problem is that you raise the alert, right? And the countries know that they are having a problem. The issue becomes that what to do to respond, because the human resources have been really stretched thin to respond to COVID. They have financing issues at the Ministry of Health where resources have been displaced. So it's really hard to do something, even though you have the alert right there. So for this year, we're going to see some surprises. We expect the final data is going to be released. Well, whatever we get by the end of June, we'll release it on the 15th of July. And the picture, it's looking surprising for some places. And it's not homogeneously affected, certainly not. And it's not only one typology of countries. Certainly countries with displaced populations, fragile, conflict are affected more. But then you have surprising places that have been quite affected. Yeah.
Thanks. Anton and Bhargavi, you want to add anything?
I mean, I think when you're talking about spatial heterogeneity in a humanitarian crisis, the levels of vaccination are so low that it becomes almost a sort of a little not irrelevant per se, but it's incredibly difficult to really look at the factors that are impacting access to the vaccine at that sort of level. At the end of the day, these are incredibly fragile healthcare systems, and they are not able to deliver the vaccine. And part of that is obviously also kind of structural issues. Part of that is just global access to vaccines, and the ways in which these vaccines are being delivered through MOH systems and therefore bypassing humanitarian systems. It's about ensuring that there are staff to deliver them that aren't being subverted from other important programs, as Anton has mentioned. And so I think the sort of the factors that are impacting coverage in humanitarian systems are a little different to kind of perhaps what you're asking about. I don't know if I can sort of make it clearer than that.
Yeah, no, thanks. John, do you want to respond to that?
I have a question. I'd like to pick up on Anton, on the idea that you closed with, or one of the ideas you closed with around this idea of multiple battlefields, or the fact that in comparison to previous epidemics in Ebola or in West Africa or Haiti with cholera, that there is really the kind of scale, the geographic scale of this pandemic is different. And so I remember early in the pandemic, there was a lot of discussion about, like, when we're thinking about immunization systems, can we draw analogies from previous experiences from Haiti and from West Africa? And I know, Bhargavi, you talked about some of the lessons that perhaps we didn't learn that we should have learned. But I'm interested, if we have, heaven forbid, another global pandemic, and we know that it's going to be global. What are the factors associated with kind of the globalness of this pandemic that have presented special challenges for delivery of immunizations and VPD control? What kind of things would you give the future sets of policymakers advice to say, like, if this is really not going to be regional, we're going to be global, these are additional factors you have to think about? Does that question make sense?
Yeah, no, I think it's a very good question, but I'm afraid I really don't have the, I mean, not probably the best person to ask. But I would say, like, given what we saw, something that, for instance, was quite clear is that the variants, COVID variants, they appeared in countries that were poorly vaccinated initially, India, South Africa. So perhaps you have to rethink about this allocation of vaccine and the fact that COVAX didn't work as expected. What can you do for that? And yeah, I mean, that's probably one thing. But yeah, I guess there are so many things to fix. You will ask like different people with a different answer. And so also the balance is what you can really do. But yeah, I guess perhaps Bhargavi or Karina other ideas.
Yeah, I think it's a good question, John. I think we talk a lot about a landscape of needs as opposed to trade-offs, right? So we certainly saw money being available for COVID vaccination, and it pulled away from case management of other diseases. It pulled away from malaria services. It pulled healthcare staff away because governments were being, or even agencies were being asked to report on COVID. I mean, it isn't just vaccine-preventable diseases, of course. We saw a wholesale pivot away from malaria rapid diagnostic tests. So we couldn't get malaria rapid diagnostic tests because companies chose to invest in COVID tests for which they would get a lot more money. So I think it's about how things have been incentivized to be delivered. And that is, again, as I say, taking awareness of this landscape rather than of kind of trade-offs. I think that the framework for vaccination in humanitarian emergencies helps us make decisions about whether we should or should not vaccinate a certain disease. What was quite interesting with COVID was that somehow that got subverted because of the pandemic perspective as opposed to an outbreak or epidemic perspective, and that skewed the playing field. At the end of the day, I guess we also have to think about just frank need and frank burden and the risk. And so, it was very sad that measles vaccination programs have been so depleted, in the face of Ebola, for instance, or in the face of COVID, when we know that the implications of these diseases are far huger in many of the populations in which we work in. That has to be balanced against making sure that people are not protected just because there are other health needs. And that's a question of just ethics, equity, and also our ability to deliver multiple programs at the same time, and what kind of support is available for delivering those programs at the same time. Because often, just the resources to kind of juggle multiple numbers of programs just weren't there. Of course, the other problem with the COVID and what happened is that we couldn't get staff movement in the same way. So a lot of us were grounded in our home countries. I haven't left London in a couple of years, and it becomes very hard to put together programs remotely. So, there were a whole number of reasons, I think, that inhibited prioritization. But personally, I think a lot of that has also just been about the system and how it forced us to make choices as opposed to kind of a landscape of needs. Over.
I would just add to that it's so difficult to think of the trade-offs when you're in the middle of the crisis, right? It's just, you think that as an afterthought, and then a cascade has been, like a domino effect has been put in place, and the far-reaching effects of that domino chain is just, we're still grappling with that collectively. And then even with the crisis in terms of displacement of populations, the insecurity for food, all these things are, we haven't seen half of it yet. Yeah.
Thank you all.
Well, I think we're out of time. There's tons of questions and we could continue a really fascinating discussion, but we'll have to end now. And I'm hoping the discussion can continue online. And so thanks to all of our panelists, both this session and the earlier sessions, and our audience for this great discussion. And I'd like to thank all my co-organizers for their help in putting this program together. So some of the important points we've heard today include the complexity of the pro and anti-vaccine ecology. There have been very significant consequences of COVID-19 on VPDs, many of which are yet to be realized. Hesitancy can be addressed through a variety of methods and considering cultural norms and is really important. We've heard about the importance of trust and the role of humanitarian crises. And there's a lot more that I can't summarize here. Remember, this entire day has been live streamed on our YouTube channel, and you can find links to that and more information at prepare-vo.org. We'll pick up again tomorrow with the epidemiological and immunological factors in VPDs at 10 a.m. on the same Zoom link. Thanks again to all the participants, and hope we'll see you soon. Thank you.
Thank you very much.
Thank you.